As you may know, for congenital heart exams, there are several main goals to the exams. This includes defining the segmental anatomy, quantifying flow in various vessels, and also assessing the ventricular function and the size of the ventricles. So the rapid and automated technique that I'm going to talk about today for this, that's a volumetric approach, is a single sequence 4D flow scan. We perform this with contrast enhancement, and it is comprehensive. You'll see that it provides both the function and flow as well as the anatomy in these cases. It's great for technologists because the workflow is much simpler. You don't have to have a detailed understanding of cardiac anatomy and much less having a detailed understanding of abnormal cardiac anatomy. As you can see that after you get a volumetric scan that covers the whole chest, after the fact, you can retroactively reformat images into any plane you want. So for example, here you see in the bottom right, there's the rendering of the whole chest, but then you see in the other panels, the standard views that are in the valve plane, the 4-chamber view, and also a 2-chamber view. So I'd like to walk you through an example of using this as a single sequence acquisition that is greatly simplified from doing conventional lengthy scans. So here we've acquired this the scan. Again, it's a 4D flow. You can see in the bottom right that the whole chest was covered. However, in order to obtain the standard views that we would like, such as in this example, a short axis, the 2-chamber and the 4-chamber views, there's an automated detection of the landmarks of the heart that then performs the reformatting into these standard chamber views. So when you open up an exam, you see these types of views. Additionally, there's an automation in terms of segmentation of vessels when determining the flow in these vessels. So here's an example where you can see that there's a valve. This valve, I've clicked on it, and now I'm in the valve plane. And now if I go to a panel, I can scroll to the temporal frame that I'm interested in, click once over that vessel, and now you see the vessel is automatically segmented. And we can see that there's the flow in the vessel that is a little over a liter per minute. So this is just a nice example of automated calculation of flow in any vessel. Again, this is retrospective after the patient has left our imaging suites. Similarly, we can obtain ventricular function from these exams. So I talked first about flow, and you saw how that was calculated. But similarly, on these 4D flow acquisitions, we can segment out the ventricles, both right and left in this case, and determine the cardiac output and ejection fractions. And in this particular case, I'll note that the heart rate was exceptionally high, 150 beats per minute, but we're still getting very good image quality. So here's just that same case, and if you can see in the top left panel, there is a defect between the atria, and so you see there's shunting of flow from left to right with 0.6 liters per minute that was quantified to flow through that shunt. The same case, now you can see, in this case, there's a pulmonic valve, which is abnormally located posterior to the aortic valve. And in this case, we can see that it is a pulmonic valve that is bicuspid. And you can see that fish mouth type of appearance of the bicuspid valve. Here you can see very nicely the pulmonary arteries. So you see the branch PAs, and this gets to sorting out the anatomy. So again, we talked about function, flow, and anatomy as the 3 primary goals of these exams. So this is just a nice view of the branches of pulmonary arteries. Again, in this same case, you can see that not only was there the shunting at the atrial level, but there's also a patent ductus arteriosus. And so here you see the flow is left to right. And again, it's 0.6 liters per minute. This was also right aortic arch. And now here you see the outlet view very nicely, both along the long axes of the outlets as well as in the plane of the valves for the outlets. And you can see this is a transposition anatomy where the aorta is anterior and the pulmonic valve, which was bicuspid, is posterior. And interestingly, in this case, there was one other anomaly, which was an anomalous left subclavian that was coming from the left pulmonary artery. And so this is a volume rendered view where you can see that very nicely. Here's just another look at that anomalous subclavian, but looking from posterior. So for this case, I've shown that we can calculate flow in any vessels. So I'm showing you just a few different vessels listed to the left, where you can see flow has been quantified in the pulmonic artery across the atrial defect, the patent ductus arteriosus, aorta, pulmonic valve, and also that anomalous left subclavian. But also in addition to that, we have the quantification of the ventricle volume as well as its ejection fraction. And similarly on the right, which was also segmented. So if we look at this case from this single sequence, we've obtained the following information. We know there's a detransposition of the arteries. We know it's a bicuspid pulmonic valve. We saw the patent ductus arteriosus and quantified the flow through it. We also saw that interatrial communication and also quantified the flow through it. Got a great look at the right aortic arch and the anomalous left subclavian, and also quantified the shunt ratio as 4.3 and gave ejection fractions in the ventricular volume. So very nice quantitative exam from a single sequence that just covered the whole chest and did not require dedicated technologist training in cardiac MRI. I want to just point out one other aspect of this, and that is that in all of our phase contrast exams, there are eddy currents that lead to errors in our flow quantification. And this can be corrected. With our 4D flow technique, there is an automated eddy current correction that's performed. So here in this particular case, you see these areas that show in a pink overlay. This is showing regions of non-static tissue or air. And so those are segmented out automatically, and then an eddy current correction is applied. So here you're seeing images before the correction is applied, and you're seeing the velocities shown in the right-left direction, AP and SI. So for instance, if you look at the top right image, you will see that there is a shading across it that is from dark to bright, and that is reflecting the eddy current errors. So now you'll see that these get corrected with this automated correction approach, and so now you have accurate velocity estimation. Again, this all happens behind the scenes. You can touch this up if you want to and hand tune it, but for the most part, this is all automated.
Hello, and welcome to our session. This is Talib Kubaisi, the MRI clinical leader at GE Healthcare. Today, we will scan together an interesting advanced topic about the cardiac 4D flow. And I am in one of our show sites in Saudi Arabia at Al Musa Hospital. We will be scanning on our 3T system, Signa Pioneer, using the air coil. So to start now with the parameters, we will go on your MR console, navigate to GE library, to add sequence, and then protocols, and then cardiac advance, and you will find already protocols, as we can see over here. There is two protocols, one without contrast and one with post contrast. And as you know, it is better to be post-GAT for better vessels detection, and this will allow for a higher SNR. As you are waiting the 8 minutes to run your MDE, you can run this sequence directly after the contrast injection, and the duration time will be around 8 to 10 minutes, and this is actually depending on your patient breathing and the heart rate of your patient. And the interesting thing is that this sequence is free breathing, as we said, and thanks to motion robust data. And as you know, for the cardiac, usually preferable to have the shim volume. And here, since we are going to include the aorta within our scan, so we can adjust a bigger shim volume. And as we said, this is easy because this is a 3D axial prescription, and it's better to have an isotropic voxel size with around 2.2 millimeter cube with a field of view 38. And if we move here, we can adjust the matrix size to be 170 by 170. Our flip angle that we will use is 15, and this is strongly influences the SNR and contrast, which is important for vessel segmentation. So you will adjust your box on the plane localizer, axial, coronal, and sagittal, as we said. As we can see, the timing is 6 minutes 28 seconds, and here is our ECG reading. And once we have adjusted the first part with the detail, we will go to the vascular. This is a little bit important. You know, an important user defined for the phase contrast MR parameter is the velocity encoding, which represents the maximum flow velocity that can be acquired. And it depends on the pathology. Usually without pathology, we keep it as 160, as we can see. And as you know, when the underlying velocity exceeds the acquisition setting for velocity encoding, we will have a velocity aliasing can occur, which is typically visible as a sudden change from high to low velocity within a region of the flow. And if aliasing artifacts are present, accurate flow visualization and quantification may be compromised unless anti-aliasing correction can be successfully performed. As a general rule, to capture the best image quality, the chosen velocity encoding should be represent the physiological velocity of the vessel of interest and be adapted to the measurement of interest and present hemodynamic conditions. Usually the typical setting for velocity encoding are 150 to 100, from 150 to 200 centimeter per second in the thoracic aorta, 250, 400 centimeter per second in the aorta with aortic stenosis or coarctation, from 100 to 150 centimeter per second for intracardiac flow, 50 to 80 centimeter per second in large vessels of the venous system. Usually for the cardiac, we go with phase to acquire 20 and phase to reconstruct 20, we will keep it as it is. Now, when we speak about the acceleration, as we said, VIOS 4D is the 4D flow imaging technique. The acquisition delivers fast imaging with the use of 8-fold undersampling, as we can see over here, using a hypercat acceleration, including both single and view sharing frames for higher temporal results. Now, while we are waiting the sequence to be done, we will move to 3 slabs, and this is without contrast. So, non-contrast 4D flow difference compared to the post-GAD actually is the flip angle. So once you adjust your planning, here we can see that flip angle is 8, which is enough to detect the signal. And as we said, this is if we want to run the sequence without contrast. And as I mentioned, this is enough to detect the signal, while on the other hand, the SNR is strongly dependent on the inflow effect. Therefore, the flip angle can be and is often higher than 8 up to 15 with contrast. Sometimes we only need to scan the aortic valve or the aorta. So what we can do is we can decrease the lux per slab, and we can change this to oblique, and on the axial we will run this sequence as a para-sagittal. Usually we look at the ascending and descending aorta, and you can adjust your slab. In this way you will be having a smaller area to scan just to get the aortic valve, aortic arc, ascending and the descending aorta. Now once we finish the sequence, we will see how the images are reconstructed, seen directly on the window, and this is actually shows the robust reconstruction from the engine that can reconstruct this huge data in very fast scan. So we are almost ready to finish the sequence, and as we can see we still have around the 6 seconds and the sequence is done, and the system directly will reconstruct to you the images on the screen, and in this way you are done with your case. As we can see here, the images are being reconstructed very quickly, as we can see, and if we have a quick look over the images, we can see the beauty of the image quality with the 3 breathing technique and the removal of the motion.